Hi, Dr. Driscoll. Thank you so much for being here.
Thank you.
I'm really excited about your research. Can you tell us a little bit about what you're doing and why you think it's important?
Absolutely. I started out, actually, I'm a patient, and which got me interested. I don't have multiple sclerosis. I have Ehlers-Danlos syndrome, which is a collagen disorder, and we are very prone to CCSVI, as I found out. So we're also great kind of mouse models, if you will, because we're so affected. So honestly, to get started with it, I was interested in helping myself and my children, and then Ehlers-Danlos patients suffer so much, then we have no answers, and I knew this was part of the answer. So I needed to research it. So I started out, I was an eye doctor before I got hit with a virus, and got on professional disability because I was slammed. I mean, it put me in bed for 3 years. It was very, very bad. And now in research full time. So I started by looking inside the eye, because the eye is indicative of systemic illness, and I wanted to see if I could find evidence of CCSVI in the back of the eye. And I did, and found evidence of other things, and that kind of got me started down the road to more clinical trials, et cetera.
What is your syndrome? I mean, what does it do?
Sure. Ehlers-Danlos syndrome is very underdiagnosed. Probably 90% of us are never diagnosed. We have defective collagen, which makes up 80% of your body or so. So you can imagine if it's defective, it can affect quite a few things. We have loose joints, but I never really considered that as being any big deal. But we get hit, about 70% of us at least, get hit with autonomic dysfunction, where everything in your body that you should be able to do without thinking, your heart rate, your breathing, your blood pressure, your digestion, etc., just basically stops its normal monitoring systems. Everything just goes out of whack, and that just disables you like that. So we call it POTS, or postural orthostatic tachycardia syndrome. People just suffer terribly with that, and we had no answers. So we have, because our collagen is defective, we tend to have a certain type of collagen very similar to the change that you see in, say, multiple sclerosis patients or other patients who develop CCSVI, which is why we tend to develop CCSVI so easily, and why we're great ones to work with to figure out what's going on, too.
So do you think you're a good population to work with because you have fewer other symptoms like MS that might complicate the picture? Is that
Actually, we go on to develop MS and other autoimmune disorders such as rheumatoid and lupus, and so now we're taking a second look at those conditions. Autoimmune? Really, and seeing what everything has in common, looking at quite a few illnesses and have hit on quite a few things.
So since you know there's a CCSVI connection, and you mentioned that in your particular disorder that it's very difficult to diagnose and people are not being diagnosed.
Right.
Could it work backwards? Could you detect CCSVI and then determine that perhaps they had this syndrome?
It's possible. Every conference that I go to, say if I go to a multiple sclerosis conference, for example, I will always find people in the audience who have undiagnosed Ehlers-Danlos. That has never failed. You go to an Ehlers-Danlos conference, there's always patients with multiple sclerosis because we tend to have both, or eventually some of us will develop both. So there's definitely crossover. I think it's so easy to screen for. People don't realize how easy it is to screen for it. Once you're exposed to it, of course, now it's very easy to screen for me. And as an eye doctor, for example, my husband's an eye doctor also, and he knows how to screen for it very quick and easy, and that's why we don't believe it's uncommon at all. But absolutely, in fact, I'd like to see more doctors do a quick screening for it.
What is the screening?
Basically, we check the hypermobility of the joints and look and see, for example, if you can touch your thumb to your forearm or put your palms flat on the floor while you stand up, if your elbows hyperextend, etc. That's the main thing that we look at. That's called the Beighton scale, and we rate people according to the Beighton scale. We look at skin signs like easy bruising and stretchability of the skin, and start to put some of the pieces together. We tend to get early arthritis, and you look at family history and see if you see some of the symptoms there. And that also pulls you toward that diagnosis if perhaps that's what's going on.
And you mentioned that one of the reasons you were concerned was because of your children. Has there already been shown to be a genetic component to this disorder?
Ehlers-Danlos is genetic, absolutely. Both of my kids are affected. My son has actually had angioplasty for CCSVI. He had it at 13. I think he was the youngest one at that point to have it done. And my daughter, I'm certain, has it too. She is a little bit less affected. She has not been triggered. Viruses are a huge trigger for us. That's what got me. That's what got my son. Accidents, like a bad car accident or trauma, is a big trigger, as is hydrocephalus, pressure on the brain from fluid. And one of the retrospective analyses that I did looked at head circumferences of Ehlers-Danlos patients in the first 15 months of life if they developed this autonomic dysfunction later. And indeed, we found that we have external communicating hydrocephalus, which is probably more than you want to know, but it's fluid on the outside of the brain pushing in. That's bad news. There's medication for it, which is wonderful, and now we know what to look for, say, in our children, for example, to try to prevent some of the changes down the road. But
so what are you seeing when you look into the eyes of a patient that helps you diagnose CCSVI?
Boy, I can pick it up like that. I have gotten so good. It is a little bit easier to pick it up in an Ehlers-Danlos patient who either has multiple sclerosis or doesn't than, say, someone who has multiple sclerosis without Ehlers-Danlos. It is easier, I will say. But I did a blinded study with 30 normals and 30 affected patients, and I had over 90% accuracy in picking up patients who had Ehlers-Danlos and MS with CCSVI. I had about a 68% accuracy if they had MS only. And what I see when I look back there, and what my thinking process was if we had a reflux of blood or a backup of blood from the veins in our neck, could it go all the way up through the capillary sinus and show up in the fundus of the eye? And the eye tells all. So I took a look, and first, as all good scientists do, we pull up our own images for patients, right? Pulled that up and just cranked the magnification and magnified it. There it was. I found it. The veins were enlarged, and they were what we call beaded, like sausages on a string, if you could imagine. Worse on the side with the worst CCSVI, which is also something that Dr. Simka's study with an OCT also found. It was worse in the affected side with the worst CCSVI. But we also found, unfortunately, an abnormal artery to vein ratio. It's usually about 2 to 3. The arteries were too small and the veins were too big, and that's a bad combination. And especially with Ehlers-Danlos, our arteries were tiny, showing probably lack of perfusion to the eye, but also we picked up atherosclerosis in even the very young patients with Ehlers-Danlos. And we do tend to develop abnormal lipid profiles, bad cholesterol, if you will. Once we're triggered, multiple sclerosis patients also develop abnormal lipid profiles, and as do other conditions that we're looking at that may be related to CCSVI. So that was more than what I was expecting to find, but it's amazing by looking back there what you can find. But absolutely, you can see it in the eyes.
So what in general can be learned about neurovascular disease by looking at the eyes or the vessels in the eyes?
I think, number one, what jumped out at me was that there was abnormalities there, and that they were so evident. We didn't look at them closely enough before. We didn't magnify things enough. In a routine eye exam, when we look in the back of the eye, we would never look that closely. And we would never compare the two eyes, that much magnification, that closely. But basically, that it indicated or it hinted of systemic disease, too. That perhaps we were dealing with something that wasn't just dealing with veins in the neck, but was perhaps a systemic problem, and perhaps causing the atherosclerosis, perhaps causing smaller arteries, and of course the larger veins. So headed down the road of what was causing those arteries to be small, what was causing the atherosclerosis. We kind of knew what was causing the larger sized veins, now that we know about CCSVI, but it was just kind of a jumping point for some of the research that I started.
What exactly is cavernous sinus theory? Can you tell us how it relates
yes,
to these diseases?
this is something. I'd hate to think that being a patient is an advantage, you know, but honestly, when you're dealing with some of these odd symptoms, it is definitely an advantage, because I would hear from patients about some symptoms, and frankly, I had no idea what they were talking about until it happened to me. And then all of a sudden it's like, okay, now I think I can figure this out. But I had thought, if the blood is going up through the cavernous sinus into the back of the eye, which it was, we could see that. The cavernous sinus is an unusual structure. It's bound by the temporal bone and the sphenoidal sinus bone. And it has an artery run through it, which will be fine. It has a vein that runs through it. And if the venous pressure is high in that area, the artery is going to be okay, because the pressure is so high in the artery, it'll push right back. But there's 5 cranial nerves in the cavernous sinus that could easily be affected. One that is very delicate and tortuous and makes a 90-degree turn, if you will, in the cavernous sinus is called the sixth cranial nerve that controls the lateral rectus of the eye. And that is the eye muscle that turns the eyes outward, if you will. If you want to look to the right, it involves your right eye. If you want to look to the left, it involves your left eye. If there's slight pressure on those nerves, I assumed we'd see some symptoms, and that the symptoms may be intermittent. They may be positional, depending on how we're flowing, etc. And indeed, that's what I found. And the first time I noticed it was I looked off to the right at my car radio, and it looked like it was moving away from me. And that was very repeatable. And using the eye doctor geekiness instead of freaking out, I was fascinated by that. And I realized, by doing a little cover test, if you will, test the muscles, that I was having a partial lateral rectus palsy on the right eye. And that was keeping me from fusing the images very well. And instead, your brain interprets that as a change of depth perception. And so after studying that, and I studied the other eye, which never seemed to do that. And indeed, I could tell that I could see double if I looked very far off to the right. And closest I could see, yeah, it is a little bit double. And then another nerve in there, well, actually 2 of them, can cause facial pain and sinus pain. And I'd hear that from patients a lot, and I myself experienced just this horrible facial and sinus pain for no reason that I was aware of. I had no sinus infection, nothing got rid of it. But indeed, the pressure on those nerves could be from increased venous pressure inside the cavernous sinus. And I think that's why those symptoms come and go, and totally discombobulates a lot of neurologists, because either they expect you to have double vision, or you don't have double vision. You don't have double vision that comes and goes, and we do.
So how can a patient who feels that they're having these symptoms, but they can't seem to get anybody to diagnose them properly, what should they do?
They should be evaluated for CCSVI, honestly.
Are most eye doctors now open to that idea and capable of conducting that test?
I am so sorry to say, I think most eye doctors probably haven't even heard of it.
So how do you get the word out? How do you help the doctors to help the patients?
I think getting the word out is important for all of the medical professions, including being eye doctors. But it involves so many systems of our body. I think we need to get it out to everyone. And social media, I have a website, for example, that I put out educational videos on and spread the word there. But any way that we can get word out, these conferences, interviews, that sort of thing, I think is important. Publications are wonderful, clinical trials are excellent, but we definitely need to spread the word.
And speaking of clinical trials, you mentioned a little bit earlier, and I think it might be the same clinical trials that are referenced in your work, that are 30 patients and 30 patients. You had 30 normals and 30 affected patients? Yes. One of the things that keeps coming up as we're talking to people is that they don't feel that there's enough work being done with the normals.
Right.
That, you need a greater baseline of normals to truly understand what's happening.
Right.
Do you feel that in your work as well? I mean, is that something that you intend to try to broaden?
I think it's important for scientific research to always compare to normals. So we just need to do that. It lowers the number of questions about the studies that you do. But I've also come to the realization that I'm not even sure what a normal is anymore, because so many of us, for example, are undiagnosed. And when we come across normals who have CCSVI, well, I had congenital CCSVI, I have no doubt, looking back now. But I went 46 years without a symptom that I was aware of it happening. So I would have been considered a normal, and I was anything but normal. I just hit it very well. So I do wonder, when we say normals, are those just currently unaffected patients? And if that's what we should be calling them, because unless we're certain that they don't develop anything down the road, we have to use that term. No, no, there really isn't. There really isn't. So, yes, I do think it's important we include normals, but I have some doubt that normals are actually normal. So if that makes any sense.
So one of the things you also mentioned was that your son has been treated.
Yes.
Did you diagnose him?
Basically. This is something that, again, being a patient really helped, because I couldn't find anyone to diagnose my postural orthostatic tachycardia syndrome. I self-diagnosed that. Finally had that confirmed, that that's what I had. And then I really thought I had Ehlers-Danlos. I had to fight and crawl and scratch to get that diagnosed, since I had that. And then I knew my children were affected. We screened them. But I knew what the symptoms were, and I had those symptoms, and I could actually feel the blood reflux, things like that. I knew I had vascular issues before I even knew what CCSVI was, actually. I was looking for something to help with something going on funky. Okay, not only in my neck, but I knew I had too much pressure in my head. So I knew I was dealing with fluid dynamics. I knew I had the symptoms of that. My son had those symptoms, and indeed he became disabled for 3 years. He wasn't even able to be tutored. He was so ill. So yes, we had him evaluated. I knew we would have CCSVI, and indeed we had slam dunk CCSVI.
And who diagnosed both of you? I mean, what particular specialist would a patient go to that might have a better handle on diagnosing CCSVI?
Great question. An excellent question. My neurologist just shut me down. I mean, he just shut me down, and so I had to pursue it myself. And I called around to find out what centers were doing it, and I didn't know if I should have a sonogram or an fMRI. I ended up with an fMRI because I love the idea of getting an image too, and I wanted Dr. Hakey to review my images. I thought that was important. So I did go have an fMRI and had Dr. Hakey review them, but I could tell as soon as they gave me the images, and I'm in the car, kind of pulling them up and looking at them, and I knew it was CCSVI then. But I knew going in that that's what I had.
So perhaps for a patient that doesn't have the medical background that you do, where would they start? Pull up perhaps the Buffalo Center or Dr. Hakey and use that as a starting point?
I think it's a great starting point. You want to do some research. You want to go where you're comfortable. Someone with a lot of experience, a center with a lot of experience, I think is important, especially a sonogram, because there is a learning curve to that one. And the interventional radiologist, I interviewed quite a few, or researched quite a few, and spoke to them. Wanted my son to have the same interventional radiologist that I did, because he was so excellent. But you do need to do your homework and ask around. Some people are able to travel across the United States, which we did. Some people can't. Some people need to stay more local. So everybody's different there. But I think checking credentials, checking experience, finding out their success rates, et cetera, is important.
And you mentioned, I think, that your son was one of the youngest patients to have CCSVI?
I think he was the youngest at that time.
Wow.
Yes, he was very brave. We were very proud of him.
And did you also have the procedure?
Yes, absolutely. I had it before him. I've always used myself as a guinea pig. So I told, I tell everyone, I've donated my body to science while still using it, because I knew we were dealing with fluid dynamics. And I thought, okay, they can do a post-mortem, but there's not a lot of fluid dynamics when you're dead. Okay, so I need to try to figure this out while I'm alive. So I did try a lot of different things, based on research and based on what I thought was going on, different medications, find out what was working, what was helping, what was not, etc., before I ever involved my children or told the world anything. So yeah, I went through it first and realized that would be fine for him.
Have you had slippage? Some of the patients have said they have.
Absolutely. I re-stenosed, and I think I know why. So that's going to be one of the talks today. And
can you tell us why?
I think I can. Yes, we're looking at inflammatory cytokines, and it's amazing what we can do with that now. And one of my posters out there explains how it can affect the heart. And I don't want to get into too much lingo, but it takes a few different substances and actions to occur, and we end up with left ventricular diastolic dysfunction, as do multiple sclerosis patients, for example. So I put all that together and looked at what inflammatory cytokines were involved and medications that target those inflammatory cytokines and the mast cells that amplify them. And indeed got on mast cell treatment. What a help that was, I cannot tell you. And then when I could focus on a particular cytokine that I knew was involved, wow, what a difference that made. So my son and I were so inflamed everywhere. I mean, from conjunctivitis, gingivitis, an inflamed uvula, my chest was inflamed. When I went in for angioplasty, I think we were just setting ourselves up for restenosis. Had we gotten a hold of that inflammation first, then I think we might be able to prevent restenosis. And the wonderful thing is that we can measure inflammatory cytokines now. It used to be only researchers could do this, but there are labs that are now taking an interest in it. And we've started looking at profiles for Ehlers-Danlos patients with POTS, and they are frighteningly out of whack. Say some inflammatory cytokines being 20,000 times what is normal. We're pretty messed up there. So we need to reduce that inflammation. I think we'll be able to help with restenosis.
So what's next for your work, Doctor?
Oh, I am so excited. I don't know if I can get this in time, but I think I figured out something that got by us. And I think because the neurologists weren't looking, and I had to learn neurology at home, but when our internal jugular veins become dilated with CCSVI, they are actually putting pressure on our vagus nerve. And that affects any organ from the neck on down to the lower third intestine, excepting the adrenal gland. And indeed, the studies have already been done showing that the vagus nerve involvement is causing our other organs to fail and cause gastroparesis, IBS, out of whack liver enzymes, gallbladder ejection fractions that are bad, heart irregularities, tachycardia, bradycardia, et cetera. I mean, it's just from here to here, all the way down. So vagus nerve involvement, I think, is going to be my next research area.
What have I missed? What haven't I asked you? What's the most important point you need to convey to us, Dr. Driscoll?
Wow. If I had to say in 1 minute, the take-home would be inflammatory cytokines in combination with CCSVI, I think, is critical. And then how that involves the vagus nerve opens it up to so many more conditions than we ever thought CCSVI was involved with. It's going to be amazing, amazing.
Thank you so much, Doctor.
Thank you. Appreciate it.